It's short, yeah. Why don't we go, so if we do 20 minutes now, and then
Good morning, everybody, and welcome to the next plenary. It's lovely to see people coming back so quickly. We do appreciate your time. I know we are cutting it fine for conversations, but we are going to try and keep as closely as we can to getting you out at lunchtime so that you will have your full lunchtime break to have a catch-up chat. So for those who haven't met me, I'm Associate Professor Holly Seale. I'm from the School of Population Health at the University of New South Wales. I'm based in Sydney, Australia. I'm also one of the Bhan advisory committees and have been helping with getting this conference together. And at that point, I'd like to shout out to Sabin. A huge congratulations for including a topic like this into this conference. I think that is really should be acknowledged. As mentioned in yesterday's opening plenary, there are currently 103 million displaced people worldwide, of which 53 million of them are internally displaced within their own countries. These population groups are at higher risk of contracting infectious diseases and obviously then from suffering from severe outcomes and consequences. This is due to living conditions. It's due to access to healthcare. It's due to racism. There are a range of factors impacting on the outcomes of these groups. And let's not beat around the bush. This isn't just in conflict zones. So this topic of today's plenary is about conflict and marginalised communities. So as I said, I'm from Sydney, Australia. For those who may not be as well acquainted with Australia, we have over 300 different languages spoken. We have over 500 Indigenous languages. Yet when I look at our immunisation resources, guess what language they're written in? You can shout that out. It's pretty obvious. They're all in English. That is a challenge that we face. And what the outcome of that is that we have inequity in our vaccine coverage across the lifespan for those who are Australian-born versus those who are born overseas. So we have inequity, and that pattern is present across every country, whether they be high, middle, or low income settings. And that's what we're going to talk about today: marginalisation, culturally and racially diverse communities across settings, and those that are living in conflict zones. So joining me in this plenary is a range of experts from a range of different countries, and they all have fabulous bios. But because of time, I have to just leave it to one line. So you're going to have to trust me that these people represent the experts that we need to hear from. So firstly, I'd like to introduce Dr. Magid Al-Gunaid. Dr. Al-Gunaid is a medical doctor who specialises in health systems management and public administration. He's been with GHD EMPHNET for 6 years, first serving as the polio and immunisation team leader, and currently is the public health program director in his country. Next to Dr. Magid, Dr. Bhan, Anant Bhan, is a researcher in global health, health policy, bioethics and mental health with over 20 years of experience. Originally a medical doctor trained in India, he's then gone on to do bioethics in the University of Toronto and currently leads a range of research projects in areas around mental health, health equity, participatory research and community engagement. And definitely not least is Dr. Amaya Gillespie, who's an experienced researcher and change strategist, having earned her PhD in behavioural science. She has over 20 years of experience with the UN and has been in a range of leadership roles in health and education, international health and development and emergencies. And her current role is as senior behavioural scientist with UNICEF's Regional Office for Middle East and Northern Africa. So thank you for joining me on the panel today. I'm going to kick off. And so we are certainly going to invite questions. So I'm going to keep to time and make sure that we also have questions from the audience. So please, if you hear anything, note it down, and I will be calling for audience participation shortly. But can I please start with you, Magid? Amongst the conflict-impacted communities that you work with, what do you think are the critical challenges impacting immunisation at the moment?
Thank you very much for this opportunity, and I think I'd like here to highlight that I'm coming from a region where more than 50% of the countries in the region are under different emergencies, instabilities. It's a complex situation, which is the Eastern Mediterranean region. So most of the population are suffering, and can you imagine that what will be the situation for highly vulnerable groups, including marginalized groups? I'm coming from a region where some countries, 10 years ago, the coverage was 95, 98%, and now it's lagging behind 50. And coming from countries where the completely self-funded immunization program and now zero contribution to immunization. So it's totally dependent on external aid. So really, it's a very hard situation in general. And if we will take the context that even for marginalized groups and for those highly vulnerable groups, it's more complex now. Traditionally, we have certain segment of the community marginalized due to some cultural issues, due to some historical background. But now with the internal displacement, it's more complex. I will not call it synergy, but also, unfortunately, that there is now different factors creating more marginalization, more marginalized groups in these countries, either in terms of politically, culturally, socio-economically. So there is different factors contributing for this. These countries, as I said at the beginning, are suffering from this extra burden with failure of maybe the public sector or the government to provide basic health services, including immunization, highly dependent on external aid, which is a major issue related to the long-run sustainability. There is clear declination in the coverage rate based on fixed health facilities. So in some countries like Yemen, like Syria, where there was destruction of infrastructure, the coverage by fixed health facilities is less than 30–40%, which means that they are highly dependent on outreach mobile teams, which is non-sustainable. It's externally funded, and that's, I think, funding is one of the issues. Taking into consideration the growing rumors and misinformation, it's not a major issue, but unfortunately it's growing and it's increasing. And sometimes also it's more institutionalized. I can say it, that even ministries of health in some of the countries, they are anti-immunization, particularly in general, and that will definitely affect those marginalized groups. So that's an overview about the status in the region, and I think my colleague,
do you want to expand on those thoughts? You're working in these areas too.
Yes, as a behavioural scientist, what we're trying to do is really add more or make it more conscious and more overt what the behavioural science can offer the situation. So when you hear of the historical position of routine childhood vaccination in the region, very, very high coverage, very, very high acceptance, but this recent dip around COVID, etc. But we have, in terms of behavioural science, it's a habit. The region has the habit and the acceptance of routine childhood vaccination. But it's now been 3 years that COVID sort of created that break in the habit, mainly due to structural issues, mainly because it wasn't available. You couldn't move around, you couldn't go to the service, or the service wasn't available to you. The sooner that we can address this habit in behavioural terms, the better for us, right? The longer it goes on, the harder it's going to be, because it'll feel like a new behaviour as opposed to reminding people of something that we normally do. And I think there's been some very interesting learnings for us due to COVID, but also against this backdrop of all these other pressures in the region. And one of them is that, and I've heard several people speak about this, that we have sometimes inadvertently undermined ourselves by talking about the fact that people who are not yet vaccinated, or where vaccination has fallen behind, we've called it hesitancy, when actually it's because people couldn't get there. They're actually open. So we've been talking much more about vaccine acceptance on a continuum rather than vaccine hesitancy. So they're increasing vaccine acceptance. And this is particularly important too, to consider who we are working with. So in some of these countries, like we're talking about, for example, Syria, where they're going into 13 years now of sanctions. At the moment, not so much active conflict, but a number of 5-6 different parties who are controlling different areas of the country. So movement is difficult. But when we're talking about vaccination to this population, this is a very sophisticated population. These are people who are educated. Everybody is affected. So the concept of marginalized community is quite different. And I think sometimes we come into it with our own view of, what these people, what their agency is or is not. And we really do need to listen, as so many speakers have said to us. So I think the context and using the tools that we have available to us to listen, particularly around trying to increase the use of technology, for example, because in conflict settings you often can't physically go and talk to people, but to actually use things like the social media platforms, social listening, these things have been really great assets to us.
Thank you both for those opening comments. And certainly I would love to hear more about the use of technology and those approaches we can use to enhance uptake. But can I dig a little bit further then into some of these problems? And, Dr. Magid, you said about funding. How's COVID impacted funding? We've seen obviously lots of funding provided to support COVID vaccine programs, but is it going to continue?
Okay. Also, it's in the region, it's different experiences. So yes, some of the countries received funding, and it's highly dependent on external funding. Some countries, even with shortage of funds, they mobilized internal resources, and that was just an exceptional case where they were able to mobilize, which is not the case for the routine immunization. Other countries, like Yemen, for example, they didn't introduce the vaccine at all. Maybe they vaccinate a few thousands of people, and you cannot say that the COVID has any impact on the immunization program in such country. And also other countries like Syria, many countries are with very low coverage. So it was not a significant change on the immunization program. However, as I said, that most of these programs are highly dependent on external aid, and highly, especially for immunization. And even during some discussions with colleagues, just last week, I was in Syria and they are discussing, and they said even the co-financing for Gavi, they are not even paying the co-financing, it's zero. And this one of the countries where the whole program was totally funded by the government. So I think funding will be a major issue in taking into consideration the cost of introduction of new vaccines, as well as the delivery method. Now they are delivering most of the vaccines through the mobile teams and the outreach activities, which is an additional cost. So really it's a major challenge for these programs to sustain their programs over the long run.
Thank you. I'm going to swing over to Anant and ask him firstly for his thoughts before I come to the more positive space of this. And we were talking just before this session started about a recent UNHCR report that was released in July last year that actually identified that there are 30 countries around the world that currently restrict health service access for refugees and asylum seekers. And, that's probably tip of the iceberg because there are restrictions in other ways placed. But, your work is around policy. Could you share some of the immunisation-related policy and program design gaps that you think are currently impacting these populations?
Sure. Thanks, Holly. So, one of the things I want to start off by speaking to is that we speak about marginalization as a process, but marginalization often doesn't happen overnight, right? It's a long form of ostracization of communities, of individuals, and that experience is what usually causes the lack of trust in health systems, in vaccination programs, and in larger outreach by public services, right? Because vaccination has to be situated within the larger life experiences of individuals and communities. And that's where I think recognizing that lived experience is a form of expertise, that when we say that we want to work with communities, we really need to respect that and try to understand where they're coming from and why is it that they might be reluctant or there might be a lack of acceptance. Sometimes language is an issue, even from yesterday or day before, we've sometimes used hesitancy as a word, we've used defaulters as a word, right? And that's labeling of individuals and communities without perhaps digging into the nuance of where those experiences come from. So I think that's important to recognize and try to respond to. And this also is partly a function of representation. So when you speak about conflict situations, migrants, queer populations, persons with disability, how much of representation do we see of them in our health services, right? So do you have enough doctors who are or nurses or paramedical staff who are queer or are openly identifying as such, who are persons with disability, who understand the health needs of these communities and are perhaps better able to help design services which would be accessible and affirmative in nature. So that, I think, is a design question which we also need to talk about, because it's one thing to say that we have we've heard the communities and we want to design programs, but unless you make fundamental changes also in the way who runs those programs, that might be an issue. So I think that is where COVID has been an interesting pandemic experience, but it was also an experience where a lot of communities saw the response being almost like a parachute response. So if some of you would have seen visuals where there were vaccination teams doing mobile outreach who would go chase individuals into fields and say that we have a target, we need to get to 100% vaccination coverage, so you need to get vaccinated. But these were communities which have never been touched by the health system earlier. There has never been any outreach. Their health needs have never been acknowledged. There were never outreach services designed for these communities. So the first time that they see a health system response is someone coming with a vaccine and saying, get vaccinated, right? So and then we say if they are reluctant or if they say no, and then we label them as being hesitant or defaulters. And that, I think, is a fundamental issue of trying to not recognize that there are historical issues which dictate why communities might respond as such. To the larger policy question, hence, I think one, of course, understanding the needs of these communities becomes extremely important, and that's where longer-term partnership with communities is important. I mean, if you look at the research arena, for those of you who've done research, you will know that the most successful community engagement happens in environments where you don't have one-time research interactions with communities, where you actually build a longer-term program, where you work with communities over a long time. You provide services which are not just specific to one project, and that helps build a certain understanding that this research project, this research team means well, that this is a program which perhaps belongs to the community, and it's not an external university or a research group just coming in to try to collect data. So I think one is certainly acknowledging the needs. Two is recognizing certain communities, certain individuals will need prioritization. And in our classical priority setting paradigms, we do not usually acknowledge that, right? So as you saw reflected in my colleague Bhakti's presentation, there might be young people, for example, who have multiple comorbidities, who have disability, but they will nowhere be in the list of priorities. Their needs will not be recognized. No one is advocating for them. So how do we ensure that we are able to do that in a way that people feel respected? Ultimately anyone, if you walk into a hotel, if you walk into a health center, you want to be recognized as an individual with rights. You need to be seen and you need to be respected. If you don't get any of that, it's unlikely that they will come back. So if the health center is not affirmative, if the health center is not accessible, then it's less likely that the individual would want to access health services. So I think from a design perspective and the way our health systems are built up, we really need to do a lot to change the experiences of communities, and then the interventions around vaccination, around outreach, around services will perhaps become interventions which the communities accept much more.
I hope people are tweeting at the moment, because there were some lovely quotes that have been said across all of that. So if you haven't had a chance to send a tweet out, I encourage you to do so now. And thank you for those thoughts. And I'm going to call on the other panel members to respond to some of this as well. But I just want to throw in the mix that, in the literature, there has been suggestions that one way to maybe try and reduce inequity and ensure vaccine programs are delivered appropriately is to actually put targets in. And I know that not everyone loves a target, but are we at this space? Is that a long stick that we don't need yet, or is it something that needs to be considered?
Yeah. As we were getting started here, we said we should really argue with each other and shake this up a bit, but I just can't find anything to argue with you about. There are so many great points. On targets, that's been an interesting one, and I'm sure many of you also have worked in other areas. You've not just worked in immunisation, so in a whole range of development areas, we set targets. One of the things I think we've learnt, though, is that a global target is not that useful, that countries need to define the targets for themselves. And I think that is tremendously useful when countries have their own targets, even though they like to play with the denominators as well, which is, nice, good. I like to see the creativity in that, but it still means there's focus. And I wanted to also just reflect on this idea that, in the Middle East and North Africa region, Not every country is in conflict, but just about everybody's affected by the spillover, which I think is what Dr. Magid was saying as well. But it isn't only conflict. Our climate is also a very big issue in the region, and particularly water scarcity. We're the most water scarce region in the world. The thing about, and these things are related, but with conflict implies mistrust already. And we talk a lot about the need to build trust in communities, but actually, in order to trust, you need to act. In order to trust someone, you want to know that someone is trustworthy. And I think this is, a small sort of tweak in language, but the idea of trying to demonstrate trustworthiness in services, in governments, etc., what that takes. It's consistency and reliability, competence. And so this idea of a good service experience. But rather than, asking people to trust you, like asking the community for something, it is something that on the system side we need to earn and build and, continue to work with. It's quickly lost and very difficult to build. And on this idea of targets, priorities, I think COVID really showed us this, but as soon as you prioritise someone, you've deprioritised someone else. I think it's possible, again, using behavioural science and, the idea of cognitive biases, again, small tweaks in language to say, this service is not yet available for young people, or this is the first phase. In the next phase, we expect to make this available to others. And these small tweaks in language just make such a huge difference down the line. But I think the other very, very important thing is about in a conflict situation, the idea of chasing people through fields with the vaccine, the mental image is already frightening. But giving people what they need, first asking them what they need. But it's so important that your service is relevant. This does build trust in a sort of phased approach, the ability for you to access communities and to engage communities in what it is that you have to offer. But we have to provide relevant services. It needs to be timely, and the service experience itself, needs to be decent. Integration of services is also what we're talking about in a phased way. So often we are delivering multiple different products, services in different places, in different points in time, when it could be done in a more bundled way, to combine these things. It's harder to do because you've got to coordinate very much upstream, but it's so much more effective, and particularly for the community. And just lastly on this idea of trust, I think it's really important to think about trust is developed locally, and this idea of the health workers and everywhere we looked, we did 23 country study, 3 points in time series study. Everywhere you look, health workers are the most trusted. Utilising that idea, and it's not just health workers, but between difficult challenges. So, COVID's a little bit in the background at the moment. Now's the time to be building trust and delivering what it is that people need. If you don't have trust before a conflict, it's really hard to develop it during a conflict or some other major challenge.
There is a lot to unpack there, but certainly some recurring themes, and also to what we heard in the earlier session from Claire Thomas about what's been happening in Somalia, to the need for affirmative health services that are culturally responsive, that are available in language. But beyond that, also building trust with communities by listening to them about what there is what their priority is. And immunisation might not necessarily be their priority. That there may be other things there. We are running out of time before we switch over to questions from the audience. I hope you're all thinking about them, but I want to sneak in one more. And this is to you, Magid. Obviously, we've been talking about a lot of vaccines that are, needing to be enhanced with uptake, but also new vaccines on our horizon. So obviously lots of conversation around HPV, but also the inclusion of COVID into routine care going forward. What does that mean in terms of trying to roll out those programs into the settings that you're working in?
Okay, so introducing new vaccine, first you need to build the trust. Just complementing. So and I think specifically for the HPV, unfortunately in the region, there is a lot of stigma, there is a lot of, and even at the policy level, they are not highly convinced and it's not a priority. So first of all, you need to work on different levels. You want to work on the decision-making level, you want to work on the community acceptance, you need to work on NGOs and other participants. So it's a more holistic approach that you need for the introduction. Key component, which is building the trust. And as you said, that for building a trust, you need long period of time. And also this mistrust is a common factor in many countries in the region, in all public services. Maybe it's fortunate in some countries, the only credible program is immunization. And that's, people are seeking everything outside the public sector except immunization. So, and there is some reasons for that. So we can build on some of the experiences. An example, Egypt. So the program was led, or it was strongly supported by the ex-First Lady for decades. And everyone will seek immunization only from public sector. And even if it is available outside, they don't believe. So there is some lessons that you can build on it. You need to better understand the situation. Maybe our past experience in reaching unimmunized children was based on remote areas with rural communities. Now the situation is different. We need to better understand our target audience. We need to better understand the needs. And I think even now the concept of communities in these urban slum areas it's completely different, and it needs to be tackled. So we need to understand. And before thinking about the introduction of new vaccines, there is opportunities for the introduction. Many countries in the region are also eligible for Gavi support, and that's an opportunity. So I think we need to rethink about our strategy for the introduction.
Thank you. Anant, I'm going to throw it to you for the final thoughts.
Yeah, no, I just wanted to make a quick connect between the issue around trust and targets that we talked about. Targets are great when they're aspirational in nature, but even with the best of translators or translation, it gets lost somewhere from top to bottom, right? So folks at the bottom are then made accountable to those targets. And that means that people push programs without doing all of these steps that we talked about. In the mid-70s, during the emergency period in India, because there was a certain political leader who wanted vasectomy done in a certain way, there was large-scale vasectomies done without consent, without permissions. And that has led to a long-standing resistance within the family planning program. So even now, if you look at, there are gender inequities at play here as well, but our vasectomy rates in India are well within the single digits, probably close to 1 to 2% as compared to tubectomies. And that perhaps is also a reflection of that one negative set of experiences where people saw this as the state violating their privacy, their rights, right? And so this is what we need to remember, that we should set targets, but then also understand that these targets could be misconstrued in the implementation phase. And this goes back to then what impact would have on trust.
Thank you for that. Now we are shifting over to the audience. So I please invite you to come to the microphone and ask any questions that you have. There we go. Thank you. That's okay. Whoever gets there first, I'll go with whatever side. I'll throw with you first. Thank you.
Thank you.
Good morning, everyone. Sorry.
Sorry. This is Zara Jamil. I'm from UNICEF Pakistan office. My question is about vaccine trust that we just talked about. The issue in our country is that the majority of the people that we're trying to reach that are low coverage or zero dose are the marginalized communities or the communities that are affected by a lot of emergencies or natural disasters. And we are trying to build trust in those communities, but we need to be mindful about what we say to those communities. And right now, they see us as pushing COVID vaccines through COVID campaigns, vaccination campaigns, to utilize the COVID vaccine stocks that are within the country that have already been produced, and we need to use up those vaccine stocks. But at the same time, all of these people already know through the widespread social media that WHO has declared COVID emergency is over. So they don't see it as a need to get those vaccines. So how do we balance that fine line between pushing those vaccines to the community while keeping that level of trust in the government, in UNICEF, in WHO and other agencies within the country high? So that dilemma between choosing to complete the vaccine stocks and keeping the trust level high, where the community thinks that, it's a foreign agenda, they're trying to, test the vaccines on us, and et cetera. And now when COVID is over, it has translated into vaccine hesitancy and mistrust towards routine immunization as well. So just that. Thank you.
Let's go with this, and then we can, otherwise we'll run out of time. Does anyone who wants to address?
It's a very good question, and I know these are challenges which program managers face all the time. I think it goes back to that central issue that ails global health and health systems, which is that whenever you have a verticalization of a program, you also fall into this trap that our messaging, our outreach, our community engagement is focused on that one goal that we have, which is that we have COVID vaccine stocks. We need to get those out quick enough to the communities. The communities should accept them. Let's have a conversation to try to make that happen without acknowledging the larger background of health needs, lack of trust. If the axis of conversation is changed to saying, I want to hear from you first, what are the kind of health needs? Why is it that you are not comfortable visiting the vaccination centers? What have your experiences been trying to access health services? Why is it that we don't see you be able to access vaccination, whether that be for COVID or routine vaccination, and then using that as a platform to try to design a response, which could mean that some of them take a COVID vaccine, but some of them also have the agency to say no. And we have to learn to respect no as well at some point of time, without feeling that they don't know enough and we are the experts and hence we should be making the decision for them. That could mean that you lay the ground through that conversation and that trust building for a longer term engagement where routine immunization conversations, preparing for the next pandemic, HPV, future vaccines, future health interventions, perhaps there is an entry point that you have created. But if we keep the agenda on forcing vaccines down in a particular situation, then maybe that distrust might only increase in certain pockets, and that is putting yourself at peril from a longer term perspective. So my sense is that a more comprehensive health system perspective of engagement, where it is also sometimes okay to say, to receive a no, with an understanding that this means that you have to keep the conversation on, might be one way forward.
I like that. We also do need to recognise that in adults, we do see this bit of trend that when vaccines become routine and part of the national program, that it does change people's mindsets about them. And shifting it from this kind of extraordinary situation into a routine setting, we may see that naturally come to peace. And we saw that with flu. So when flu gets bedded into national programs, as opposed to being, yes, you can get it if you think you need it, we see a shift in uptake. So that's something to consider. I'll throw over. Thank you.
Good morning, everyone. My name is Anshuman. I'm a PhD scholar from Manipal University in India. My question is around the target. So the question to the panel is how to ensure rational target setting with healthcare service provider equity and service seeker equity, especially in settings with poor availability of human resources in public health sector.
You know, this is a tricky, very tricky question. Also in relation to the previous question, it was making me think about how in immunisation perhaps we've been a little spoilt. We're used to vaccines being utilised quickly and very high coverage. And again, with the example of COVID, yes, in the beginning that was our expectation. But I think in that case, we need to accept that, in fact, the uptake is going to be slow. That we'll need to do it locally. People will not come to us. We will have to do the outreach. And this is what really the switch in the strategy has been, that we will need to bundle services that people want with ones that maybe they don't want so much or are less aware of. We will need multiple contacts with people in order for them to get used to the idea. Adult vaccination, there is no adult vaccination real schedule in our region. Like it's not a thing, it's new, right? And COVID was such an exceptional situation that it's coloured almost everything else that we do. So I think this is related to your question about target. I think it is difficult to have a perfect target. I think it does need to be aspirational, but I think the idea also of bundling and this integrated services is super important. That it becomes routine, that it's not just a single vertical program. These things. You may need it in the beginning, but ultimately you have to build it into like the total system approach, because you get all these strange, distorted reactions to it if you continue that way. So I think these are factors in identifying your targets. I think it's better to be aspirational about it, but also the more data you have, the better your target is going to be. And something that we've seen is a much more social and behavioural data is available too, which helps you to see what the community thinks and feels. You know, so I think all these factors are very important in setting a target at least.
Thank you. Now, by my clock, I've got 2 minutes, but this big clock here telling me 6. So I'm going to keep going unless someone jumps off at me. Can we please throw to you?
Good morning. It's Eka Batashvili. I'm regional partner of Gavi-funded project Linked Immunization Network. And Ukraine is one of the project country. So there is no question that's the hottest place in the world. The question, it's quite general and probably it's not easy to answer, but still the government of Ukraine thinks that it's the right time and the high need of introduction of PCV vaccine in the country. But actually the ideas of different technical experts differ in this field. And some think that it's not right time for a new vaccine introduction, but some acknowledge the need of this vaccine. So I'd like to use your presence here on the panel to take some considerations for the government of Ukraine. Thank you.
I think here the context of the country will just be the main factor behind taking this decision. So first of all, we need to see the current practice of the immunization program. What is the current status in terms of coverage, in terms of delivery, in terms of cold chain, in terms of everything. And I think immunization program is highly sensitive and it's affected very easily by external factors within the country. And according to the current status and what is going on, it is not an emergency situation where you want to introduce a new vaccine during such very critical phase. So it might be that, yes, you need to prepare yourself. the government could also do some preparatory work because the introduction will not be in one day. So whatever is now applicable and could be done, they can start with it. And as I said, one example is the cold chain, for example, and to see and to assess the situation. And then it's a gradual maybe exercise, and highly advised that sometimes also during such war, such the very difficult situation, it's not an easy job to introduce a new vaccine, because also you need to train people, you need to train all the health workers. A lot of preparatory work could be started, but not up to the level of the full introduction of the vaccine. So that's just an idea.
That's a great response. So really about ensuring that health system's ready, but also priming the community to receive it down the track. So thank you to everybody. I apologise we did not able to answer that final question, but I think we had some great conversations. So a huge thank you to the panel. Appreciate your thoughts on this important topic. We're now going to shift across to the presentations for this session. So if everyone could just bear with us for a couple of seconds, we'll do some furniture rearrangement and we'll come back. Thank you. Thank you, everybody. Thank you. Okay, we're good. We're going to keep going. So we're shifting to the next phase of this session, and this is when we're going to go through the presentations from our different speakers. Okay, other speakers are coming up. Well, great. Okay, so to begin with, I invite Dr. Chattiya Nitpolprasert, who is joining us from Thailand, and her work has been focusing on people living with HIV, especially those who are most at risk, stigmatised in high prevalence groups, men who have sex with men and transgender women. And today she's going to share the results from the Adams Love Global Foundation work, which is a mixed method study which has been assessing COVID vaccine information needs and vaccine seeking patterns, decision making, and the challenges in actually getting a COVID vaccine amongst these particular focus populations. So let's go. We've got 12 minutes and you're... I think it should just be... I'd be that, the big one. Okay. Thank you. And you've got to see them down there.
Hi, my name is Chattiya Nitpolprasert. I'm a social and behavioral researcher at Adams Love Global Foundation for MSM and Transgender Health, or ALGO, in Bangkok, Thailand, and a PhD fellow at the Department of Global Health, Amsterdam University Medical Centers, the University of Amsterdam. Yeah, so our goal is focuses on technology-based HIV prevention to increase the prevention uptake, as well as to improve the linkage to HIV care, as well as referral to the uptake, and also the care continuous care for the people living with HIV as well as especially MSM. And we have done the novel intervention, which is called online to offline model in HIV service delivery, and is Asia's first project in increasing uptake of HIV. And previously, before this study, we did a qualitative study on the impact of coronavirus disease, COVID-19, on psychological and financial well-being and engagement in care among MSM living with HIV in Thailand. That's why it led to this study. And we have been listed in the review of the first year of the research in 2021 of the social and behavioral impacts of COVID-19 on people living with HIV. So this study is funded by Sabin Vaccine Institute, and because of the urgent need to prioritize the vaccination among people living with HIV, because the recent WHO report suggests that people living with HIV at any CD4 level can increase risk of developing critical health outcomes if left unvaccinated. And however, in Thailand, even though there's some mismanagement, the scene of COVID-19 vaccine rollout in Thailand is that in the beginning of the rollout, there was some quite mismanagement and some procurement issue in Thailand. But however, the government have kept up very fast, and then they bring out everything and distribute the vaccine quite well, and everybody get quickly. So, however, people living with HIV community, especially most at risk and stigmatized people, such as MSM and transgender women living with HIV, have not been prioritized among the 7 key risk groups in the vaccination program, which we call the 608 group. And the multiple challenges around vaccine information availability, access, and linkage have evolved. So the 608 group comprise people aged 60 and older, and those who are with underlying conditions, and pregnant women. Our study aims at assessing the information needs and vaccine seeking patterns, decision-making, including acceptability and hesitancy, and challenges in acquiring COVID-19 vaccine among Thai MSM living with HIV as well as other key population, including other people living with HIV, and examine psychosocial and other health determinants of the uptake of the COVID-19 vaccine, and highlight the need and recommendation of the vaccine service delivery. So what we did is we used the exploratory sequential mixed method design. So in the first phase was a qualitative phase. We did the in-depth interview with 42 MSM living with HIV across the country in the red zone provinces that you can see in the map, that they make that red zone with the highest COVID infection rates. And we did the focus group discussion with 50 healthcare providers and HIV care providers. And we used this analysis to develop the quantitative phase, the survey, due to the lack of literature in this field. So yeah, this is a process of what we did. And we did the qualitative data collection, and then we construct the questionnaire, and then we distribute the questionnaire, and then we did the analysis and data interpretation. So now I will share with you some of the comprehensive outcomes. So during the COVID-19, the difficult time of COVID-19, we did conduct the interview and focus group, like I said, 50 healthcare providers, in which they serve over 15,000 people living with HIV in different provinces. And during that time where everybody focusing on online, we have to do it offline because the HIV providers are in the forefront of vaccine delivery as well, because they have to give a service to the people of living with HIV and also try to encourage them to get the vaccine. So there's some feedback from them that one of them is that low CD4 level is a key factor in vaccine recommendation and hesitancy and uptake. Living with HIV and COVID-19 increasing among MSM and people living with HIV at that time. And mental health and psychological support is needed throughout the journey, right from the beginning when they make a decision, when they get it, and then to the end, even when they got the COVID. So the unique aspect of the population is that they are immunocompromised, and it leads to syndemics in terms of mental health, other co-infection, including HIV and COVID-19. So I will quickly go with the demographics of this participant. So in the qualitative phase, we have median age of 30 years and mean age of 32 years. People responded to the survey, and majority are MSM. Over half had monthly income below $500, and all of them in the qualitative phase had initiated antiretroviral therapy and achieved an undetectable viral load, which is a suppressed virus in their body, and maintain a good health. On the other hand, in the quantitative phase, they also had initiated ART, and 18% had CD4 below 350. So the motivation of participants towards COVID-19 vaccine includes participants express a desire to prevent themselves and family from contracting COVID as a key factors, including influencing vaccine acceptance. Some of them said, I want to receive the COVID-19 vaccine 100% because I want to be safe first, because if I get COVID, then it will be even more difficult. And also mandatory to get the vaccine from work, from accessing the service or the malls and the park, or even travel across the city, you need the vaccine. So it's called like vaccine permit. So some of them said that my workplace is like semi-forced them that they have to, if they want to go to work, they need the 2 doses of vaccine. Or another person said that the reason I decided to get because I want a certificate, they will give a kind of vaccine passport so that they can show and then they can go to different cities. Otherwise, they have to stay at home. And another motivation, which is very important, which is HIV care providers are broadly trusted by participants and play a large role in decision-making process, in which they reported having communication with their providers, including either doctors, nurse, community workers, prior to making the decision. And in the quantitative survey, most participants, 72%, reported consulting with their providers prior to receiving the vaccine. And the topic that they ask a lot is the vaccine safety. The hesitancy is fear of death, side effects, and adverse events from COVID-19 vaccine, which is, because of in the beginning, they're afraid of death from getting the vaccine. And limited choice of vaccine in Thailand in the beginning creates hesitancy among MSM living with HIV particularly, because they said that they want to wait for the mRNA vaccine as a reason for delay uptake, because their perception think that the effectiveness of safety of mRNA vaccine over the inactivated viral vector vaccine, which is first available in Thailand. In terms of context of living with HIV, the factors influencing the COVID-19 vaccine uptake is considering oneself immunocompromised. That's why it's better for them to get the vaccine. One of them said, I didn't actually want Sinovac, but I didn't have much choice. So my immunity is weaker than other people. So I want to get the vaccine as soon as possible, regardless of the brand. And concern around the COVID-19 in this context is, for example, ARV medicine, it's in the interaction with the medicine or low CD4 level, or some of them just recently diagnosed with HIV and they just started the ARV, so they don't want to receive the vaccine. And the big issue is that the perceived stigma and discrimination in the COVID-19 vaccine uptake. The fear of HIV stigma was primary reason to not disclose the HIV status at the inoculation station or centers among majority of people living with HIV. And some of them reported feeling reluctant to disclose their status, and some of them even reported that they face a feeling of HIV stigma. So the online advice from the HIV providers or even from us is offered to them. And some hospital even offered a special appointment for people living with HIV to get the vaccine inside their hospital. But this one only can be done in a small setting of hospital. So the conclusion, So we can conclude that HIV providers play a critical role in people living with HIV's information needs and HIV and COVID-19 vaccine journey. And vaccine preferences drove vaccine decision making. And people living with HIV express strong need to be prioritized in vaccination programs to overcome challenges, including fear of stigma and discrimination. So my last slide is about the recommendations and needs, which is prioritizing people living with HIV and vulnerable populations for COVID-19 vaccine information, as well as COVID-19 vaccine uptake, and the ability for them to choose the vaccine type, even from the beginning. And the fourth one is setting up, one of them giving a very interesting one is setting up the COVID-19 vaccination center, like election booths in different municipalities, so that everybody can get it. And anonymous service at the inoculation center is strongly needed. They want to go and then nobody asks them, or even have a feeling that somebody will ask them. So one of them said, I want a government prioritize vulnerable populations in the COVID-19 vaccination, and we would be able to get the quality vaccine and not leave us like general population and seek your own vaccine. So we would like to thank all participants and affiliated HIV providers, as well as Sabin Vaccine Institute and the team, and for great collaboration. And yeah, thank you very much.
So just like the opening plenary, we'll be having time for questions, but we will leave them towards the end of the session. So our next speaker, unfortunately, could not make it here in person, but Dr. Monica Berger Gonzalez is going to bring in a different focus into today's plenary. Her work has been focused around the role of traditional medicine practitioners and how they potentially could play a role in the promotion of immunisation efforts, which isn't necessarily a system or strategy that is used across countries, but something that maybe we need to consider more given the multicultural nature of many of our countries. So Dr. Gonzalez will address this topic by presenting results from a nationwide ethnographic study in Guatemala that focused on the socio-cultural moderators of vaccine acceptance amongst 24 ethnic groups, really showing what meaningful ways could be used to involve traditional healers in collaboration with public health officers. So we've got the recording. Thank you.
Good day. My name is Monica Berger Gonzalez from Guatemala. I would like to present results from a study conducted with the Ministry of Health, the Pan American Health Organization, and the World Health Organization, and my home institution, Universidad del Valle de Guatemala, on vaccination against COVID-19 in plurimedical settings. We would like to share today a bit of the data on this study. A little bit of context first. Guatemala has a population of 17 million people, out of which 46% live in rural areas, 44% are indigenous. There's a great diversity of languages, 25 official languages, of which the majority are Maya languages, but more than 150 dialects. Religious background is important since we know that belief systems have been known to modulate some of the beliefs around the vaccine. You can see about half the population is Catholic, 40% Protestant, but there's a great syncretism between Maya traditional views and wisdom mixed with other religious beliefs. The national plan against COVID-19 started in Guatemala in February 2021, rolling vaccines in phases, and those are the 4 that we had available in our territory. What is important to know is that by August 2021, 28% of adults were vaccinated with 1 dose, but you can see in the graph the behavior changed from first no availability and high demand to later on by August reluctance and rejection to COVID-19 vaccination and public health services. Upon close look, we realize that there's a very high difference in coverage between urban settings with high coverage and rural settings with low coverage, ranging anywhere from 2 to 73% of vaccination of adults. These raise the question, what are the modulators shaping the behavior of accepting or not the vaccine? The response was a national ethnographic study conducted to understand the points of view of the cultural liaisons from the Ministry of Health, health staff at the front line of the vaccination efforts, community leaders and traditional healers, household heads that were also asked through surveys, and getting different leaders through in focus groups. You can see the numbers in the screen for this sample. We did the study in 27 health areas out of 29 from August to November 2021 by social scientists mostly. And the result was 27 plans, one per region, reporting results on the perceptions, attitudes, knowledge, practices around COVID-19, fear of COVID-19 vaccine, coping mechanisms, beliefs around vaccination, willingness to get vaccinated, recommendations and preferences on where to get vaccinated, what were barriers to access healthcare, and most importantly, a deep study into communication, what was desired and not, what was working and not, with the focus of designing a better communication and education strategy. This is the sample for the country level. All ethno-linguistic groups were taken into consideration in the sample size. The idea was to be able to understand what modulators were shaping behavior of different regions and different ethnic groups around the vaccine. It is important to say that access to healthcare in Guatemala is not equal. This map shows, the colors show the level of poverty, red being the worst, and that correlates with the areas with the most indigenous populations and most rural. You can see the purple dots being the concentration of health personnel, and there's more health staff located in more urban, non-indigenous areas as well. This is an old map, but it's what we have of information. So there are great inequalities where 61% of the population in Guatemala is under the poverty line, and there is then therefore diverse for health-seeking strategies. So Guatemala matches what the World Health Organization has said about traditional and alternative medicine, where 2/3 of Latin America depend on traditional medicine to meet health attention needs. This is in Guatemala the case where we have a plurimedical system, meaning the coexistence of diverse traditional medical systems, one belonging to the state, the public health system, the private sector, and a number of traditional medicines that, in case of the indigenous populations, provide up to 2/3 of filling out the needs of the population for accessing health. Now, going quickly to some of the selected results, if you see here the graph on fear to contract and to spread COVID-19, the first group of graphs shows from the light blue to the dark blue being not worried at all to being very worried in the dark blue for 3 groups. The first one, household heads, second, community leaders, and third, health personnel. What you can see in the first group is that the fear of contracting the disease is relatively low to medium. But when we ask all these groups whether they were worried to infect loved ones, it increased drastically. You can see the dark blue going up with being very worried. This was important because all education campaigns at the time were focused around you have to get vaccinated to prevent getting severe illness, get vaccinated to save your life. And what this study showed was that there was a shift in focus needed to shift the attention to if you love your grandmother, get vaccinated. If you love your wife, get vaccinated. If you love your husband and your children, get vaccinated. And this was much more efficient and effective. This study helped create those campaigns. Another important result was what was the intention to get vaccinated? 68% of all the population interviewed was willing to get vaccinated. But when we look specifically at different ethnic groups, and you can see it in this graph, there is diversity, there's a variation. What the graph doesn't show is the high diversity between different ethnic linguistic areas in rural and urban areas, we will see later. And it is important on the graph below to see that the level of trust on the vaccine between different groups is 40% of the households has none to very low trust in the vaccine, And then you can see the second column being community leaders and traditional healers, that it increases a little bit more. And then the third column is the household heads, which have the highest level of mistrust. So the important thing to know is that this is all the areas in the country that were studied in the sample. And you can see from the red, the municipal districts under 25% of intention to get vaccinated were only 2. And then you have a huge diversity with different colors. So the point of this graph is to show you that there wasn't so much a pattern that you would say all the country wants to get vaccinated or does not want to get vaccinated. So understanding the modulators of that behavior was extremely important to create strategies per little region. The fear of vaccine side effect turned out to be one of the biggest modulators of reluctance to get vaccinated. 45% of all households and 41% of community leaders were moderate to highly worried about grave reactions. One of the problems was there were no effective communication campaigns after the first dose, which meant people were not expecting side effects and did not know how to treat them. So that it created less willingness to get a second dose. Main negative beliefs about the vaccine were that it kills people after a couple of years, or at least keeps them permanently ill for life, that the vaccine causes men and women to be sterile, that there's a chip for population control, or that is the mark of the beast, referring to the apocalypse. What is important is that if you see these graphs to your right, community leaders in orange and household representatives in blue, pretty much many of them have a high worry to suffer extreme negative reactions. And this was shaping the willingness to, or not, to go to the health post, not only for the vaccine, but to seek healthcare after side effects. So, important part of this presentation is what is the role of traditional medicine in all of this? And we saw that 30% of all households and 49% of community leaders and traditional healers reported using traditional medicine at the time of the interview to face COVID-19. And 93% of community leaders reported using traditional medicine in their communities overall for either preventing or treating COVID-19. This went all the way from herbal medicine to different traditional traditions regarding a very holistic approach with diet, exposure to sunlight, preventing close contact with sick people, and a number of things that I cannot go into describing right here. But what is important is that all 27 health areas requested creating better education and communication material in local languages with more cultural pertinence. And they realized that the strategies of using health personnel to communicate the importance of the vaccine or the risks of contagion was not working, because traditional healers and community leaders actually had more legitimacy and were perfect role models to aid in the communication efforts. 2/3 of all traditional healers reported a negative polarization done by Ministry of Health personnel in alienating users. If someone came to the health post asking for information on the vaccine and reported using plants, they would be chastised. So traditional medicine was made to be a villain instead of looking at it as a potential collaboration, a complementary approach to vaccination. People who are using this medicine for 2,000 years are going to prefer it over a vaccine that no one knows where it came from. That was what the reports showed. And 100% of all community leaders and traditional healers recommended that they should be included in the efforts of the government, because if they wanted to record local variants of a language, people would recognize better the voice of a local healer, a religious leader, a traditional leader, and they gave very precise instructions of who were legitimate leaders that should be addressed to record radio campaigns, to appear on TV, to increase acceptance and support the efforts of the Ministry of Health. Main conclusions for this project, for this research study, are that multicultural settings certainly demand a recognition of the importance of plurimedical and multilinguistic approaches to emergency response in public health. We need to plan according to real diversity and not to be so worried about how difficult it's going to be, not implement only top-down one-size-fits-all responses, but to take the effort, at least in a second phase, to really make it more culturally and linguistically pertinent. Second, that ethnographic research on modulators of vaccination acceptance against COVID-19 really has emphasized the strength of a closer collaboration with traditional medicine. So not to polarize, but to work together. And we tested it on several projects. To increase acceptance of vaccines and the confidence of the public in the public health intervention, it's necessary to recognize respectful relationship between traditional healers and public health staff, like this picture shows, where practices of each one are seen as inclusive and complementary and not mutually exclusive or necessarily in a fight. But this requires careful strategic planning. It's not going to happen just because. Finally, that promoting a closer collaboration between community leaders, including traditional healers and public health officials, will really facilitate this linguistic and cultural relevance, all the way from planning to an intervention to implementing an intervention, and particularly for communication campaigns. So we don't have more time, but I thank you very much for your attention, and I'll wait for questions on the open round. Thank you so much.
I'm going to thank Dr. Gonzalez for her comments, and I'm hoping she's going to be able to join us later, despite the fact that it's midnight in Guatemala, for questions, so I'll confirm that. Now, you'll see I've moved myself away from the podium because our next speaker and I share a love of the fact that we hate standing behind podiums and would prefer to walk around, so I'm just priming you to the fact that this is going to be her approach in her presentation. So I'd like to introduce Dr. Patricia Kilmarka, who is going to be focusing on vaccine demand and confidence initiatives, which have been used by the International Organization for Migration with technical and funding support from the centres from the CDC. So the IOM has been employing novel approaches to evidence-based human-centred design, and this presentation now is really going to be focusing on the interventions that have been co-designed with and implemented by refugees to tackle the issue of suboptimal COVID vaccine uptake amongst refugee populations along the border of Thailand and Myanmar. So thank you. I'll hand over to you now to describe the multi-layered and multi-pronged interventions.
Hello. Hi. Sawadee ka. Bonjour. I'll try my best to not make everybody dizzy. I'll try to stay still. And hi. You guys are a really tough crowd. I've been listening to the questions, and I swear I've had easier conversations with the armed groups in conflict zones. Please have mercy on me. So, just to inform you, this project is still ongoing. So I will try my best to use the time to explain the different complex processes that we have involved with the project. And our project focuses on the refugee populations along the Thailand-Myanmar borders, using the human-centered design to understand and address the suboptimal vaccination, COVID vaccination uptake along the populations. So, as Holly mentioned earlier, so this project has been funded and supported by the US CDC. And they're not just donors, they're very closely working and very involved in all the process along the way. And we are really happy for their support. Okay, so just to go through the content, first we're going to discuss the project goals, the background, the methodology, the Rapid Community Insights process, which is the Rapid Community Assessment 2.0. And I'll explain a little bit more on why we decided to change the terminologies. And we also used the different human-centered design methods, and we will discuss findings, the interventions, and also some of the prelim results of the ongoing interventions. So as I mentioned earlier, this project would have not been possible without the support from the US CDC. And these partners are the key stakeholders that make the project possible. I can see some of you sitting here is from them is IRC, Malteser International. Thank you for joining us. They're the frontliners. So thank you for coming. We also have the Ministry of Public Health, who is really closely involved, the Community Health Advisory Group, and the Kothule Hope Theological Seminary Refugee Committee, the Karen Refugee Committee, KKBBSC, and the Malamo Baptist Bible School. the goal of this project is to increase the COVID-19 vaccine confidence, demand, and uptake among the selected refugee population. For this particular target, we are starting with the Thailand site, focusing on the refugees along the borders. We use different processes involved. For example, we use the rapid community insights process to understand in a systematic way and to identify what are the actual barriers surrounding the suboptimal vaccination uptake. We also used human-centered design to create creative, innovative, and community-informed, multi-pronged, multi-layered interventions that has been prototyped, tested over and over again to make sure that it really addresses the needs of the population. And also, on a real-time basis, we conduct evaluation on every single workshops and every single interventions that we design and we conducted. And also the last objectives is to ensure the sustainability of the interventions and to create systems that will stay despite the project's existence and after the project had ended. So this is where we work. It's a really beautiful location, and it's about 18 hours by car from Bangkok. The closest airport is Chiang Mai. You also need to travel 6 more hours to get to the area. There's no electricity. There's very limited mobile signal. The water that they use comes from the river. And everything is frozen in time. You can see the houses here. They're built from bai tong tung. It's a type of tree, and bamboo. I'm not entirely sure how much you're familiar with the issue of the conflict in Myanmar. But as of now, there are still ongoing airstrikes and conflicts, bombings, and many different situations that's happening across the border. In the area of our interest, which is here, it's right across the current state, or Kothule, and they have been cut and sanctioned by the Burmese government for the past 40 years. So anyone who has been born in this area do not have any birth certificates. They do not exist. They're the stateless of the stateless. They do not have access to healthcare, no electricity, no transportation. Everything has been cut in the 40 years. There's been a lot of ongoing attempts and border health management, diplomacy, and etc. to try to improve the quality of lives along the area. But just to give you a more background context. And currently, we estimate that there is around 90,000 to 100,000 population who are residing across the 9 camps in this area. But the number changes very often, especially as the conflict escalates. We have long natural borders surrounding it, so therefore people travel across pretty much almost on everyday basis. The areas that we will be focusing on will be Melaun, Mela Maluang, and Mela. The total population in the 2 camps, Melaun, is about 10,000. This is the data of May. And Mela Maluang, around also 10,400. And also for Mela, it's a bigger population, very complex and more sophisticated. There's around 30,000 population. So, why did we decide to choose those 3 camps? This is the population, this is the general population vaccine coverage for the Thai adults above 18. So you can see the blue color is the first dose of the COVID-19 coverage. So it's above, so as of November 2022, this is before we start our project, the data is at 85% for the first dose. For the second dose, it's about 75%, and for the booster dose, it's about 40%. And across the other 7 camps, Mela, Tham Hin, Ban Ton Yang, Nup Po, Phiem Mai, Ban Mae Surin, Ban Mai Nai Soi, you can see that the coverage varies. Some are even higher than the Thai general population, and some are still quite low. However, Melaun and Mela Maluang, it's very, very low. So data as of November 2022, for Melaun, it was about 17%, and Mela Maluang, 23%. And so we were sent to discover why And initially, we wanted to do really full-on literature review and mixed methodologies. We reached out to a lot of the agencies who conducted surveys before, and several answers were given, but they're hesitant. They believe in the Book of Revelation, 666, Satan, Omen. Ben says yes. There were so many reasons. It was all pointed out that it's the population's fault. They all pointed out that they're stubborn, they don't listen, they're uneducated. So we are scientists, we believe in the evidence. So we actually went down and we said, is that really true? So we went in, this is Mela Un. And Mela Maluang map is here. From the entrance of the camp to the hospital, it's quite a big camp, and in terms of geographical location, it's really far away. The closest hospital, tertiary hospital, is 3 hours away. The police station is about also 2 to 3 hours away. And if you have to walk from the furthest spot to the hospital, it takes about 2 hours and a half by foot on this mountainous road. And this is also Malaun. Pretty similar. So we actually timed the distance and see how far it would take and how long it would take. So we wanted to make sure that we understand what's going on. So we used the rapid community insights process to understand what happened. So we went in to gather the insights and perceptions from the community of focus. And then we conducted data analysis. And then we co-designed with the community themselves. And then we shared the recommendations back to the community members. And then after that, we also evaluate and implement. The methodologies that we use is adapted from the US CDC RCA method, which is the rapid community assessment. But the reason we did not use the same word is because when we said assessment and survey and research, everybody has rolled their eyes back to you, but you can see the spine. Like nobody wants another research. It's like the 100,000 research conducted on the same population. So we wanted to make sure people understand that this is to design the interventions. We changed the name, and it also translated much easier. I think in the panelists earlier mentioned the issue of language also creates a lot of barriers. So we changed the word to the insights process. We conducted across the 3 camps the in-depth interview, listening sessions, intercept interviews, and the population is 428. We also conducted a lot of shadowing, community observation. We wanted to see what are the actual experience that they lived. And we used the snowball sampling, convenient sampling, and what was a bit different for this project is we tried the approach of using the members of the community themselves to be data collectors. So we trained 44 data collectors to conduct the research, and it was a real-time training. So within a period of 2 weeks each per site, we did the training, and we conducted the research, and we did the analysis on a real-time basis. This is what the thematic analysis looked like. It was not fun using Post-its because when it was windy, it disappeared. But anyhow, so we gathered the information. One of the main points that we really want to emphasize is we want to do capacity building for the team in the camps. And so we train them, and we hope that they can still use this knowledge after the project has ended. And for the findings, the first thing is we found that actually the word tatasu in Karen does not translate to voluntary. And that word, when it is introduced, it actually makes people concerned, and it makes people really afraid of the vaccine. Because they say, look, if the vaccine is safe, why are you using this word? Because what it means in Karen is if you dare to, or if you're willing to. And for example, if you go to somebody's house and you offer them a dish for dinner, and a dish of rice, and then they say, here, this is your rice, tata shu. They would say no. The other context that the first time they actually heard this word, tata shu, okay, it's when the voluntary repatriation campaign happened, and people were asked to go back voluntarily to Myanmar, and they say, look, my house is still exploding, my village is still burned, and there's COVID, you want us to die? So the word tata shu is linked to something else that's more of the negative connotation. And very unlike what we perceived earlier, that it's actually rumors and belief that you're going to turn into magnetic creatures after the COVID-19 vaccine, it's actually not that, but it's more of the shared experience that people were hesitant about it. Sorry, I'm really out of time. Can I have more time?
1 minute.
I know, you guys. Yeah, I'm just kidding. Okay, so, and then other points are, for example, the chronic patients and the elderly, they think it's not safe, and the fear of needles, low severity, perception that they think that COVID-19 vaccine is not new, because a lot of people already survived malaria. They think that, look, this is nothing for us. And then also the issue, as I mentioned earlier, is the accessibility. And also we had the risk communications without the community engagement. So the RC does not have CE. And then what happened is the loudspeaker has been cut at least twice in the camps. So that has been really been an issue during the COVID since the beginning. So we used the human-centered design. I'm gonna fly through this, okay? I have the front row, like, okay, you have no more time. Is that okay? Thank you. Okay, so we used the human-centered design and the different tools. For example, ideation, we invited all of them to take place, and we presented the findings and asked them about how might we, and we asked them to co-design the solution. So ideation, to those who are not familiar with this process, is actually trying to create as much ideas as possible. And these are some of the suggestions. So as a result, we have very complicated interventions that is more of the health systems approach, right? So it does not cover just on individual basis, but we already know that the problem does not lie on the perceptions or the hesitancy. There's many more factors surrounding it, and it's not just the demand side, but it's also the supply side. We also created a sense of belonging, because the refugees themselves do not feel that they're part of the discussion at all in any conversations, especially towards health. And they co-designed the logo and even the hoodie themselves. And the name of the group has been called Right to Truth, Right to Health has been suggested. Okay, I'm not gonna explain this, but okay, so this has been established to create a camp level health systems to address rumors, misinformation, to also act as the platform to provide information and also to connect with the different players who are beyond the usual healthcare providers. We also had the intervention prototype. We had a film festival, and instead of using agencies to create films, they voted to make scripts themselves. So we had a scream contest. These were some of the results. It's been edited, acted, and also made inside the camps by the refugees. We also have rap songs made. The youth group said, we don't want to play in a film, we want to sing. So I said, okay, why not? Here, and these are one of the songs. And to make sure we have the scientific side involved and they are well informed of the latest evidence, we also gathered the experts' opinions and we collected the questions from the community, and I have to stop. Okay. Anyway, so these are some of the other examples that we have for the training curriculum, and I guess I will have to stop now.
You've done well.
Yeah, thank you.
Well done for that. We'll switch back to the podium. Our next speaker, unfortunately, how we've been able to buy back a little bit of time for that presentation is that our next speaker has not been able to join us in person, and for the sad reason of conflict. Very appropriate for this conversation, but the fact that the airspace is currently closed in Sudan has prevented Dr. Mohammed Modbir to join us in person, but he was able to record a presentation. It's not going to have any visual, but it will be his message, and he really wanted to get this out to the Bhan 2023 attendees. So I'm going to get the sound going.
Dear colleagues and friends, greetings from Khartoum, capital of Sudan. I would like to send my sincere gratitude to the SABIN and UNICEF teams for organizing the extraordinary Vaccine Acceptance Research Network 2023 conference in Bangkok and bringing together early career professionals, researchers, scientists, and policymakers under one roof to discuss the vaccination effort and share success stories, learned lessons, challenges in the vaccination, and collaborate toward a better, healthier world with a healthy child. Being a young nurse here in Sudan, the last 4 years, putting a heavy burden to help to improve my community, as we have seen a peaceful revolution, the COVID-19 pandemic and military coup, while we tried to deliver health services to our communities, we will try to deliver health services to our community. And all that was before April 15, where a war broke out in all orders in Khartoum, and family and friends has not been safe. This has not been an easy thing to pass. However, the most important thing that I have learned is to cope with the situation and collect myself and work towards saving my communities. The challenges that I have faced daily in the last few years has provided me a silver lining, lifting me with experience and lessons that I could apply to help my community, including on vaccination. In 2021, my application was selected by Nursing Now Challenge and Sabin Vaccine Institute to be an immunization advocacy champion, receiving storytelling and advocacy training and co-mentorship with other early career nurses around the world. With this support, I implemented my advocacy challenge titled Enhancing Vaccine Acceptance Among Sudanese Nurses program. The program I started, including pre and post survey about vaccine acceptance, a session about vaccines, and why nurses should use their potential leadership to influence vaccine acceptance in the community. This program targets all nurses, that was focusing on nurses that are doing their internship in national services at Khartoum State. The objective of the program was to raise the awareness of vaccine acceptance among Sudanese nurses, to highlight the impact of COVID-19 globally, regionally, and nationally, to accelerate the vaccine acceptance among nurses, to correct their misconceptions and reinforcement of vaccine information. One of the key challenges that I have faced while implementing enhancing vaccine acceptance project is political instability and military coup, which we have witnessed in October 2021. This, as a consequence of this coup, we have lack of accessibility to the internet, disruption of established coordination channels that already have been established between nurses working at governmental hospitals, hospital directors, and state Minister of Health and Federal Minister of Health, leadership changes at various levels, state and hospital levels, and mental instability, which has come out as a result of deaths and injuries and dark situations that we have been experiencing during that period of time. The challenges to vaccination, I was excited to continue to work with the fellow healthcare workers and colleagues to address, but was upended the morning of 15th of April 2023. We woke up at that morning at the sound of gunfire that continued today, as today we entered 60 days of war between Sudanese armed forces and rapid support forces. This Khartoum war has impacted a lot of several implications on the population. One of the most impact of this war is hundreds of deaths and thousands of injuries among innocent civilians, power outage and difficult to access to the water supplies, difficult to access to the internet services, difficult to access to the healthcare services, including hospitals due to the road closure and the lack of food transportation in the early days, difficult to access to the essential medicines that including insulin and dressing materials due to the disruption of supply system, and high prices, which has been increased by 200 in compared to the before of this war. Displacement of skillful healthcare workforce that including surgeons, nurses, technicians, and other healthcare workers outside Khartoum as a consequence of ongoing war, difficult to access to primary healthcare services, including maternal and child health services. My response to this war is, after the first week of war and witnessing the injuries among family members, I have two parts of my family members has been gunshot, has been impacted by gunshots. The sense of responsibility has grown up, and the urgency to formulate an emergency humanitarian room has come out to provide emergency care to population in my area. What I did is communicated with nurses, pharmacists, medical doctors, medical assistants, and first aid community volunteers in our area to have a meeting to discuss the formulation of the emergency humanitarian room that will provide emergency care to injured cases in my area. A crowdfunding campaign has been started for all people living in my area to collect funding to pay for essential medicines, IV fluids, dressing materials, and minor surgery materials. Training to the first aid community volunteer has been provided related to how to deal with emergency cases and how to handle injured persons and infection prevention control measures. We started at school, then 2 weeks later, we communicated with the Director of Primary Healthcare in our area to open the Primary Healthcare Center under emergency humanitarian room responsibility. This PHC center enables us to provide additional services that include management and follow-up for cold cases and chronic cases, including diabetes, mellitus, and hypertension, laboratory services, antenatal checkup, and routine vaccination. Routine immunization during time of war. Since we opened the primary healthcare center, we received several questions from mothers about routine childhood vaccination. We listed the number of children for immunization. So we communicate with the primary healthcare vaccinator to check the available vaccine for validity and safety measures. After confirmation of vaccine validity, we schedule 2 days in a week for vaccination services until the vaccine was consumed. Despite the shortage in essential vaccines, including measles, OBV, IBV, and rota vaccines, we vaccinated over 50 children with routine vaccination. The vaccine successfully covers the children doses, and now we are out of stock. As this war is progress and almost exceeding 2 months, the issue of routine immunization is critical in the affected areas inside Khartoum. All humanitarian actors must work toward facilitating the process for receiving humanitarian aid and routine vaccination to the conflict areas in Khartoum, nor we will have long-lasting impact of missed vaccination doses. Our primary healthcare center is operating without any government or non-government or NGO support. We operate via community support effort, as I highlighted by crowdfunding measures, and we have successfully provided emergency care for more than 30 gunshot cases, dressing for more than 75 cases, and antenatal services for more than 20 cases, and more than 100 routine checkups that including chronic cases and that including cold and chronic cases in the last 2 months. As we carry forward together to ensure all communities receive life-saving vaccination, we must realize that we can only accomplish this if the international community continues to do all it can to support daily functions and emergency care in a complex setting like this. I look forward to hearing more on how we can collaborate and learn from each other to create solutions that enable us to provide or to deliver for our communities. My key message is to all international humanitarian actors attending this Bahrain conference is to pay attention to the matter of providing emergency care services and routine childhood vaccination to the people in the conflict area like Khartoum, that as we are witnessing today, because this is very important things, and it's important things that to do lobbying and advocacy using global organization in order to facilitate the process of receiving humanitarian aid response inside affected area in Khartoum, nor we will never ever that will be safe for the complication or consequences of routine vaccinations. Thank you all, and good luck to all of you, and having a nice conference.
I'm sorry that Mr. Modber was not able to join us. You know, he is a community health nurse. He is a young nurse leader. And beyond the prize that he was awarded from the Sabin Vaccine Institute, he was also previously awarded the International Nurses Day Award last year for his role in leadership in immunisation. So I encourage you to connect to him and to our other speakers. One of the key themes in this session has been around tailoring and making sure that you are working with your audience. My audience out there now desperately needs to get to lunch. I can see it on your faces. So we are going to stop this session. I'm going to thank the people who have spoken now and encourage you please to grab them straight away. Kate's looking at me.
Sorry. We actually do have Mohammed with us virtually. It is a huge surprise, and thank you so much. I know his perseverance is pretty inspiring. We also, I believe, have Monica.
Oh, then I'm going to
So we do have two virtuals. So I know we are over time, but it would be wonderful if at least we could get maybe one question per person, per panelist, because we have virtual speakers.
Excellent, and thank you to you both for joining. Monica, I know the time zone isn't great, so that's wonderful. And to Mohammed, thank you. Always gone. We've lost him.
Thank you very much. Stefan Mandić-Rajčević from Serbia, Momentum USAID project. I would like to ask Patricia, just since you were cut off, what was your conclusion? What was the final message you wanted to tell us?
Hi, thank you. This is working. Hi, thank you so much, Stefan. So the main key point before I squealed and escaped is actually human-centered design really works because it puts empathy back in our public health interventions, right? And I had more results to show you that how it worked and how it actually did work. So since March 2022, for 6 months, in the camps they had basically less than 5 vaccination, like less than 5 people got vaccinated in 6 months. And once we rolled the campaign, within 5 days, we vaccinated, I think it was 400 people. And that's more than 30% who came to the campaign. And more than half of which were the first dose of vaccine. So those who were hesitant or undecided decided after listening to the information and the scientific situational analysis that they want to make that decision. And so the key takeaway, I think, would be just to put feelings back into place, put empathy back into our health interventions, and also to listen more, to listen to what they have to say, especially with the refugees in conflict setting, because they did and they are going through a lot. Thank you for that question.
That is fabulous. Do we have a question for Monica? Otherwise, I will quickly throw one. Is anyone wanting to get up? Monica, you have stayed up and it is past midnight now, so thank you. So I am going to throw you a question and then let you head off to bed. But I think, to me, one of the kind of underlying messages from your talk is that kind of unconscious bias that we all have and has been traditionally there around the role that non-traditional healthcare providers or traditional healers can play in providing the promotion of immunisation. How do you think we check that, and how do we get governments and other organisations to have better engagement with these actors?
Thank you for the question. Just quickly, so everybody can go have lunch. I guess until we generate evidence-based approaches, showing what happens in a scenario where you involve traditional healers and one where you do not, it remains a rhetorical argument. So I guess, for example, receiving the Sabin grant to be able to conduct research and show a case study that significantly improved acceptability of immunization when the whole strategy was based on key messages created by midwives and traditional healers with the researchers and the communication experts. And when we use the legitimate channels that they saw fit for each region. And when the specific workshops for generating messages for youth, indigenous or non-indigenous, for elders, etc., were done in this participatory, transdisciplinary fashion, then we were able to present decision makers with concrete evidence that this is not just a want, but an actual need. Want to improve a more inclusive approach to effective immunization in plurimedical settings, in highly diverse settings where there are many epistemic systems, many knowledge systems and cultural backgrounds. The one-size-fits-all doesn't work, but it's hard. And in my experience, there's great antagonism because it creates complexity. And often we have to generate the evidence that it's worth it. So I think now we can say that the evidence that we've been able to produce in Guatemala has led us to have these conversations at a regional level, explaining why it works, how it can be done, what methodologies were developed that are cost efficient, and those that we should avoid. But mostly the payoffs, like the feedback loops that are positive for showing how those indicators on vaccination move. I guess until researchers and policymakers work more together, and I guess especially social scientists, to understand these subtle domains of culture, accessibility, preference, all of these 5 A's of access, I guess we often neglect, decision makers neglect too. So usually we focus on availability, affordability, accessibility, and we neglect adequacy of care and acceptability. And I guess that research, not only by us, but by many others, has already shown that until we really involve those legitimate healthcare providers that do not belong to the state services, these pandemic efforts and responses will always be a bit crippled.
Thank you, Monica. That is a lovely response to wrap up this session. Thank you, everybody. We are only 6 minutes over, so I appreciate your patience. I appreciate the time and efforts of all the speakers and also our Fireside chat members earlier. So can you please give another round of applause to them? Thank you, and I will look forward to chats over lunch on this subject. Cheers.
We will be reconvening at the concurrent session at 1:30 to be back on track. Apologies to everybody.